Hello and welcome everyone. This is another AONM webinar, the Academy of Nutritional Medicine, and we're just very, very honored to have Dr. Ray Perrin with us this evening, just back from Toronto, just flew in this morning. So thank you so much, Ray, for making it.
My pleasure.
I'll just introduce him briefly. Dr. Perrin is going to talk about Through the Looking Glass, Long COVID, and the Perrin technique, both titles of which refer to, well, this title refers both to a really seminal article that he wrote during COVID, and now the book that he has just brought out recently, called Through the Looking Glass. His research since 1989 into ME, chronic fatigue syndrome, has expanded our knowledge of diagnosis and treatment of complex neurological disease. This was after he qualified from the British School of Osteopathy in London in 1984. In July 2005, he was awarded a doctorate by the University of Salford, UK, for his thesis on the involvement of cerebrospinal fluid and lymphatic drainage in ME CFS. Since 2007, he has held the academic post of Honorary Senior Lecturer at the University of Central Lancashire, UK, and is also Honorary Clinical Research Fellow at the Faculty of Biology, Medicine and Health at the University of Manchester. In 2015, he joined the International Faculty of the German School of Osteopathy and teaches osteopathic theory and practice to students in colleges all over Europe and to the medical profession worldwide. His research into ME, CFS, and now long COVID has been published in major medical journals, including the British Medical Journal, and he has written best-selling books on his protocol, the Perrin technique. Ray, I think I'll leave you to introduce everything else you'd like to say about yourself.
I think you said that. Said enough. I think who
No,
it's a bit of imposter syndrome now. Who's Gillian talking about? Yeah.
he was also. I'll go right to the end because this is so long. You've got so many, honors to your name. He was the winner of the inaugural Research and Practice Award from the Institute of Osteopathy in 2015. And he's been appointed a vice patron of the University College of Osteopathy. So very, very much looking forward to everything you have to tell us this evening, Ray. And everyone who's here, please put your questions and comments in the chat or the Q&A as usual. And after his presentation is finished, we'll have time for questions. Thank you very, very much, Ray.
Well, thank you very much, Gillian. It's lovely to finally be here with an webinar. I've sort of threatened to do this for many years, and we're finally doing it, so it's great. I'll share my slides. I think that's it. You should be able to see my slides. Yes, it says participants can now see your application. So if the AI of Zoom works, it's correct.
That's fine.
Right, wonderful. Okay. I'll just turn off my phone. I didn't realize I've got it on here. Sorry. Right. Okay. So we'll start. So Through the Looking Glass, long COVID and the Perrin technique. We're going to work out why I called it, I called the book Through the Looking Glass. Not that I have anything against Lewis Carroll and Alice in Wonderland, but it's not really related to that, although the book does have lots of quotes. And Alice in Wonderland, when he wrote Through the Looking Glass, it was based on the fact that when Alice went through the looking glass, everything was upside down and back to front, and very much the case with COVID and long COVID. So as we'll see, so the Through the Looking Glass is related to the paper that I wrote in 5 years ago when the pandemic was announced. And when we knew about the coronavirus, and we've known about the coronavirus for many, many years. And you're looking at this coronavirus here, and many of you are thinking, well, we know what that is, that's COVID-19. But you might be surprised that what we're looking at there is the common cold virus. It's not it's a coronavirus. So we've known about coronaviruses for many, many years. And many times people have had coronaviruses and ended up with a post-viral condition. And we saw this before in SARS-1. So when we had seen this in SARS-1, which was 2003 in Toronto, and it's not just a coincidence, I've just been to Toronto now, we're talking about the research that they did then. As we'll see in my talk today, we knew that after SARS-1, which was 2003, there was the survivors, quite a few of them ended up with this post-viral fatigue, otherwise known as ME. So on the night of the announcement by the World Health Organization, which was March the 11th, 2020, I wrote this paper, and it was published online in June, and then it was they went further. And it's interesting that it was on my wedding anniversary that I wrote this paper, March the 11th, 2020. Because my wife, most people don't spend the night of their anniversary writing a paper, but I knew I had to get it out, and we did, and it was the first paper predicting that there was going to be after the pandemic worldwide, there was going to be millions of people with a post-COVID-19 syndrome, now called long COVID. And it's quite amazing that nowadays now the rough estimate is 65 million people with long COVID in the world. So it was all from the work of Harvey Moldovsky, who was a senior physician in Toronto in 2003. The virus spread from Hong Kong to Toronto, and they managed to curtail it. It didn't spread worldwide, so it was never a worldwide pandemic, but it was an epidemic that unfortunately killed quite a few people. 20% of the people who got the SARS-1, the severe acute respiratory syndrome, developed really severe symptoms and died. And a lot of the survivors ended up with ME. So it all went back to my physical findings of ME CFS. Once I knew that ME CFS was a post-viral generally condition, but we have lots of different triggers that lead to ME CFS. The same with COVID. Long COVID was never the cause of the problem, it was the trigger. So the virus is never the cause of these conditions. It's the final trigger. What I did see was there was a spinal problem in all these patients, and that goes right back to my original research. And you see this picture here, and I don't expect some of you might be osteopaths out there, or physios or manual therapists who might recognize that the spine of this chap is not a really healthy spine. The top part is what we call kyphotic. The middle part is flattened, and then the bottom part is more kyphotic again. It's a reversal of a normal curvature, and this shouldn't be flat in this area. And this is what I was seeing. One of the signs I noticed to aid diagnosis of ME was this physical phenomenon of spinal problems. In the spine, we have the nervous system as well as the brain, and the central nervous system goes down the spine. The spinal cord is a continuation of the brain. But we have, besides somatic nerves that we feel sensation of pain, and send messages to muscles to get them to move, we also have the autonomic nervous system. The sympathetic and the parasympathetic are the basic two parts of the autonomics. There is a third part, the enteric, which controls the gut. But it's basically the sympathetic and the parasympathetic. And we know the sympathetic chain comes out from the spinal cord at in the thoracic area, basically T1, the first thoracic junction, first thoracic segment, and goes right down to L2, which is in the lumbar spine. But it spreads all along the spine and out to the rest of the body. And the parasympathetic, mostly the vagus nerve, comes from the upper part, from the brain, and also from the sacral. You have parasympathetic nerves there. And they work in conjunction with, in unison with each other. They work together. Sometimes they work antagonistically. But we know much more about the autonomic nervous system than was taught to me as a student when I studied in the British School of Osteopathy, which is now the University College. And that was, I qualified in 1984. So we weren't taught, we were taught that the autonomic nervous system, as this lovely diagram from the University of Manchester's physiology department, shows arrows going in one direction. And these arrows show efferent fibers going towards the organs from the autonomic control, is mostly, we believed, from the brain and from the spine to the organs, to the viscera. We now know it's totally different. Most of the messages are coming from the organs to the brain and to the spine. So it's much more an afferent system than an efferent one. And we also know that the lymphatics are controlled by the autonomic nervous system. Primarily, and what we do know is they're controlled by sympathetic nerves. So every lymphatic collecting vessel, bar the very, very small capillaries, have sympathetic nerves attached to them, and they pump the lymph out into the bloodstream. And if you look at the pictures of the lymphatics, like this one here, you'll see there's no lymphatic system in the head, in the brain. It was always believed there was no lymphatic system in the brain. So the question is, why do we need a lymphatic system? And we need a lymphatic system for large molecules. Small molecules can get into the blood, through the capillaries, because it's a filter system. So small molecules get through. The larger ones can't get through. So they need another system. And that's where the lymphatics come into play. The lymphatic vessels have walls that have actually a filter system, but allowing much bigger molecules in. Huge molecules can squeeze in to the lymphatics. So it takes the small molecules as well. And so it takes most of the gunge. In fact, there's now talk of the fact that does the blood take any toxins in? Is it all going through the lymph? But that's another debate. But the main thing is that we need the lymph for large molecules. That is one of the main reasons. It's a major part of the immune system as well. We have T lymphocytes, B lymphocytes, natural killer cells that are all lymphatic cells. But we do need the lymphatics to help drain off larger molecules. And once they're in the system, then they go through lymph nodes and they get broken down, through the spleen and get broken down. Eventually, they end up in the bloodstream underneath the collarbone. And that's the lymphatics. So in the brain, there was never believed to be a lymphatic system in the brain and the spinal cord, the central nervous system. Why? Because there's a barrier, a natural barrier. And we know this. We've known it since it was all theorized for many, many, many decades, even centuries, but it was proven in the 60s with electron microscopy that the blood-brain barrier was a real barrier. Packed tightly together, these tight junctions of the endothelial cells stop any large molecules entering. The only molecule can enter that, or very small molecules such as water, but larger molecules can't. And if larger molecules can't, then blood can take all the toxins that get into the brain, and we don't need a lymphatic system, which is why scientists and doctors for years said there wasn't a lymphatic system. So now we know different. So what is really going on in the brain? And as Orville Wright said, if we all worked on the assumption that what is accepted as true is really true, there would be little hope of advance. So my theory started with ME in 1989, and in the early 90s, I joined the University of Salford, and I did my research in the 90s. As Gillian said, I eventually got a doctorate in 2005, 20 years ago, in this field. In the field of the neuro-lymphatic system, affecting which wasn't believed to be in existence. And even when I qualified, we had no absolute proof there was a neuro-lymphatic system, a lymphatic system of the brain, which is now coined the glymphatic system. But 20 years ago, this hadn't been proven. I did research to show that it was going wrong in ME. That was my hypothesis, which was supported by the work we did, but there was no absolute hard evidence that I was right. And there was no evidence at all that there was a lymphatic system of the brain, even in 2005. And those days, when I started work in the 80s, ME was known as the dreaded yuppie flu. A lot of doctors didn't believe in ME. I still hear from patients that my doctor doesn't believe in ME. He thinks it's a load of rubbish. He thinks it's all in the mind. It's not a real disease. So it's still happening around the world today. But in the 80s, and when it was derogatory termed the yuppie flu, most doctors didn't believe in it. So I did research into a disease that really didn't exist officially, and on the whole process that didn't exist officially. But now we know differently. So what do we know? Well, what my theory was started because I knew the hypothalamus in the brain, which is the mother of the hormonal system, measures all the hormones via a mechanism and controls it by a mechanism called biofeedback. Hormones such as insulin, which are huge, it's a huge molecule, enter the brain. Now, this is interesting because it's not just the hypothalamus, but it has to be, the hypothalamus has to be a major area because it's the mother of the hormonal system. And hormones enter the brain, hypothalamus measures them like insulin, and then sends messages, in the case of insulin, back to the pancreas to tell the, via autonomic nerves, to tell the pancreas that there's enough insulin. And this is the basic biofeedback mechanism that goes on around the body to with hormones and autonomic nerves to balance everything, to keep everything right, to keep the right metabolism in your body, to keep homeostatic mechanisms going. And the locus ceruleus is in this diagram here, and I always say to people that was my Van Gogh phase because it's the wrong color. Locus ceruleus in actuality it means a blue spot for you Latin scholars, and it is a blue spot in the brainstem, which is blue, slightly bluish hue because of noradrenaline. In America and Canada, they call it norepinephrine. And this is similar to adrenaline, and this is controlled by the hypothalamus, by certain areas of the hypothalamus will send messages to the locus ceruleus to produce the right amount of norepinephrine, noradrenaline in the brain. So I said this area, its sympathetic nerves control the lymph, and now we know they do, but this is obviously going to affect the lymph in the brain. If there is a lymphatic system in the brain, then norepinephrine is going to be a very important part. Noradrenaline is going to be a very important part, and that's why I drew this picture in my thesis in 2004. I drew this picture based on the work of Netter, but I added in the hypothalamus locus coeruleus, stressing those areas. And now we know there are 7 different areas of the brain, 2 in the hypothalamus, the pineal gland, the pituitary gland, area postrema in the brainstem, which is very close to the vagus nuclei, subcommissural, subfornical organ in the brain, which are there for electrolytes and salt balances. And you have 2 areas in the hypothalamus, median eminence and organ vasculosum, both allowing large molecules in, and therefore large toxins can get in. And therefore there has to be a way of the toxins coming out. So as first hypothesized, going back to many years ago by early Italians and then Scottish surgeon William Cruikshank, that there was a drainage system of the brain. And Andrew Taylor Still, the founder of osteopathy, talked about the waters of the brain draining to the lymphatics. Sutherland, his main disciple, who started off, William Sutherland, who started cranial osteopathy, talked about the drainage of the brain, but they could never prove it. And what scientists in more recent years, such as Speransky in Russia, looked at the perivascular space. And there was also Roy Weller looking at the perivascular space. These are spaces around the blood vessels. They're called peri or para as well. There's slightly difference in the two, but we'll just talk about spaces around the blood vessels that supply the nerves. So all cranial nerves have a blood supply, and it's around the blood supply that you have cerebrospinal fluid draining along. And it's that cerebrospinal fluid that we call the neuro-lymphatic system or the glymphatic system. And Roy Weller was a professor in Southampton. He showed that there was definitely a drainage system when you inject rat's brain with a dye in the ventricular system. It ended up in the lymphatics in the neck. And it's this area of the main area, the olfactory pathway, that's been looked at. Speransky in Russia said this is the main drainage of the brain, and I followed that pathway, saying that the cribriform plate, which is an ethmoid bone, has small perforations. Those perforations have an olfactory nerve, a blood vessel, and a space around it. And if that space is filled with cerebrospinal fluid, if it doesn't drain off or drains the wrong way, you're going to have major problems. So all I could show my patients was this for years and years and years, this schematic showing them what I believed was happening without any hard evidence to show there was cerebrospinal fluid. And then in Rochester University in New York, they used new techniques called dual photon emission tomography, where you could see blood and cerebrospinal fluid right next to each other. You could dye the cerebrospinal fluid bright green and see the difference. And this is the paper that came out, Ilif and Co. Maken Nedergaard is a professor from Denmark who's attached to the University of Rochester in New York. And she was the one that coined the term the glymphatic system of the glial cells of the brain. And it's these, it's the dye that was being put in to very large molecules, in this case amyloid beta molecules that are linked to Alzheimer's, was put into the brain of mice, and you could see quite clearly it went through these spaces around the blood vessels, the perivascular spaces. And when it stopped working, it led to a buildup in around the hypothalamus, in the thalamus, the basal ganglia, in the mid part of the brain. It started building up, which is exactly where we expected it to. And it's not just the hypothalamus is involved that we can say for sure. It's the limbic system, the emotional side of the brain. It's also the thalamus, the basal ganglia are very important for pain. So the basal ganglia produces GABA that suppresses pain, and the thalamus, which is right next to the hypothalamus, that produces neuropeptide P. So if you have an overstimulation of the brain, it's going to trigger these things off, and the substance P, and it's going to dampen the GABA, which will increase pain. And this is what we see with fibromyalgia patients. But what recent research has looked at which area of the brain, and this area of the brain, the top frontal part of the thalamus, is showing up as being more enlarged and more engorged than anywhere else. And this is a new study done in Australia that hasn't been fully published and fully researched yet. But we know this is the area that we're looking at. So that's the area in the front part of and the upper part, the paraventricular nucleus. And that has links to all autonomic control, and it has links to different parts of the brain. And if that goes wrong, you get major problems. So you got this normal lymphatic drainage should occur in one direction into the lymph vessels and into subarachnoid space, which is a space over here, which is the space between the arachnoid and the PL membranes, which form part of the meninges, the outside being the dura. So in the dura, the outside of the meninges, you've got lymph vessels that have been discovered, and that was only recently in 2015. So this would really be exciting that we've got actual lymph vessels in the brain that's been discovered. However, it was only in mice, not in humans. And I had to wait to the year 2017 to show, so this was 12 years after my thesis, to show there was dual lymphatics. There were a lymphatic system lining the brain of humans. So there was definitely a lymphatic system going on. And the rate of fluid that's produced in the brain, it follows the heart rate. It's 50 to 100 beats a minute. And we now know from the work of Professor John Kinmont, who's a professor in London, looking at lymphatics. He died in 1991. But before he died, he wrote a book on lymphatics, and he did some research, and he showed that the main duct of the lymph, the thoracic duct, has a pump of 4 beats a minute. Now, if we know there's drainage of the brain to the lymph, and that's been proven now, then we have an interference wave. And this interference wave in physics is somewhere between the two. Now, you don't need to be, and this is what we call the cranial rhythm or the cranial rhythmic impulse. But you don't have to be a physicist to understand the formation of this sort of wave, of the interference wave. You just have to be to a beach. And you see a big wave coming in, a small wave going out, they crash together. And that same wave pattern is starting in the brain, produced by the blood, so it's 50 to 100 beats a minute, pumping away. And now it drains into a system that only has a central drainage of 4 beats a minute. So that is what causes a third wave. And that third wave, we can feel, is the cranial rhythm. And it's always disturbed with ME. That's the thing I was saying. So I published a paper on the idea of this cranial rhythm being resultant of the blood flow creating cerebrospinal fluid in the first place, and it going instead of back into the blood. Some of it, we thought at that time, some of it, now we know most of it, goes through the lymphatics. And Laura Lewis at MIT is a scientist in MIT whose team have looked into this. Excuse me. So they've said one of the big questions about drainage of the brain is, surely if the lymph is only a small vessels and they go very slowly and the blood's coming in, surely there's no way the lymph will be able to come out when there's so much coming in. The force of the blood will push the lymph the wrong way. So this can't be happening. And then we now know what's going on. During delta wave sleep, during deep sleep, that's where the main drainage occurs, and that's where we're trying to encourage. We say we give patients self-massage to do at night. But during delta wave sleep, what happens is that Laura Lewis and MIT discovered there was a reduction of volume. 10% of cerebral blood volume reduces. And this is very, very important, because if the volume reduces of the blood flow, blood and the blood vessels and all the blood in the brain, if that reduces, it's got to be replaced by something else. The brain is a fixed unit. If fluid goes out, this is called the Monroe-Kelly doctrine, and therefore it has to instead be replaced by something. So if blood flow goes out of the brain, it sucks up cerebrospinal fluid. And this sucking up of cerebrospinal fluid into the fourth ventricle over here, and then into the third ventricle, and then you've got the lateral ventricles on the side. That force of being pulled in because so much blood has gone out, and then suddenly it's going to be replaced by cerebrospinal fluid along the spine, and it comes up and it compresses the fourth ventricle. And this compression of the fourth ventricle pushes along the fluid around the brain. Now, as far-fetched as that sounds, this is scientifically validated now. And the terminology using that, it's compression of the fourth ventricle, is been used in osteopathy for over 100 years, the CV4. When we do cranial, the theory is we do some compression on the ventricular system to get things pumping again. And now we've got evidence to show that that's probably what's happening. With ME patients, this is always dampened. It's never moving the way it should do. So there's an effect, there's a dysfunction of this whole system. And if there's a dysfunction of the craniosacral rhythm, it's going to cause major problems. But the major problems cause a dysfunction in the first place. And you can get a disturbance of cranial rhythm, not from this, but from years and years and years of different stress factors, different traumas. And whenever I give a lecture now, I've always got one physio who specializes in brain concussion and head injuries, and this could lead to a drainage problem. So, and we have found so much in the last couple of years. And one of the things we've discovered, and this was only a couple of years ago, was SLIM. So I've said to you before that the membranes of the brain, the meninges, are three parts to it. The dura, the outside, the arachnoid, the middle part, which is separated by the subarachnoid space, full of fluid, cerebrospinal fluid, and then there's the pia at the bottom. But now we know something different. We know there's a fourth layer, and this fourth layer is called the SLIM. And it's only one cell thick in some parts, and it's containing immune cells, so it's very important for immunity. It's like the first defense, like the tonsils are the first defense of our body. The SLIM is our first defense of the spinal cord and the brain itself. The subarachnoid space, which is divided, goes all the way down to S2, to the second sacral part of your back, right at the bottom. So if you have a lot of toxins coming into out of the brain, if they don't, so they come out, and then if there's a damage to this, so they come out to the outside of the SLIM, and if there's damage to the SLIM, the toxins coming out will just go straight back in again, and you'll have more and more. And so this is a more detailed version of what we're talking about, the SLIM, and you've got good stuff inside and bad stuff coming out from the rest of the brain. The glymphatics drains the outside of the SLIM, and it should go out of the body and away into the rest of the system and detoxified by your liver and passed out from your body. This should be happening. But what we now know, and it should be replaced by the healthy SLIM inside the SLIM. And now we know that SLIM can be easily damaged, so toxins will come to the outside of the SLIM and go back in the SLIM, and so back in through the SLIM and into the brain. So it comes out from the brain and it goes back to the brain, a lot of it. And this is why our treatment takes so long sometimes, because some patients have got major damage to the SLIM. There's also, last year, they discovered a major factor about the drainage of the brain. They saw that the main drainage of the brain was really, as I explained years ago, through the cribriform plate. So, and there's a whole plexus, and this was in mice again, but you can see this is where the injection took place, and it went through the cribriform plate, through the optic, through the olfactory pathway, back into the brain, and some of it went into the neck, and some of it went back, and again because of the slim, and then it went eventually into the cervical lymph nodes. But the cervical lymph nodes beforehand, there was a whole plexus of cervical vessels that formed this huge posterior nasal lymphatic plexus that nobody really looked at before. And this was very majorly important in the pathogenesis of different conditions. And they saw that the drainage of the brain actually went into the neck. And now we know 50% of all the drainage of the brain goes through the cervical lymph vessels, through this hub, through this plexus. 50%, and the remainder goes out down the spine and lymphatics along the spine. So hardly anything goes back into the blood at all. Now, this is a long slide, but I'm going to just tell you what it says because this was a major breakthrough. So up to now, we had the glymphatic system, and even just with the work from the South Koreans, we could see it pass through the cribriform plate. The drainage system existed, and this drainage system, when it doesn't work, explains ME and long COVID. But we never had proof that it actually was in humans until last year. It was just in October last year, Yamamoto and colleagues showed by injecting the brain in humans who were having, so these were human subjects who were having brain tumor removals anyway, were having surgery. So they asked them, did they mind having an injection put into their brains to see from cerebrospinal fluid into the perivascular spaces and the like, and watch the drainage itself in real time. And they showed, this is one before and afterwards, where this is quite large vessels going there and there, but look how enhanced they are after a certain amount of time. And then the enhanced ones, look how dampened they become. So there's much more dampening of the signal. So there's an increase of the signal, and then later on there's dampening, meaning there's a pump mechanism going on. There's a drainage system mechanism going on of fluid in the brain, just as we hypothesized. And then on top of all that, if it's not enough, we have a chap called Joe Opessa, who's discovered there are canals running from the brain all the way down the neck that nobody knew existed. And he took photos of it with magnifying glass. It's not even a microscope. This is a superior sagittal sinus in the middle of the vein of the brain. And next to the superior sagittal sinus, you've got these canals full of cerebrospinal fluid draining from the subarachnoid space into the bloodstream. And he proved this by looking at cadavers, and he just injected dye and watched where it went. So now we know there's much more than just drainage into the blood from the fluid. There's drainage in the lymphatic system. There's a slim that needs to work properly, and trauma, and even that lumbar punctures in the spine will go into this area, and doctors would not know that there was a problem. So that's why you have some people having problems with ME and even long COVID, having problems after any lumbar punctures because it's damaged the slim. And this is the complete picture where you look at the cerebrospinal fluid draining down the canals that we now know exist, draining down the lymph vessels that we know exist in the spine, but we still have other things to find out. because we need to know how we've got proof positive now. It happens in the human body and it happens around the cribriform plate, just as I imagined many years ago when I started my research work. But what's building up there? And in COVID-19, we found there were cytokines building up, pro-inflammatory cytokines, especially interleukin, interferon gamma, and interleukin 7 and 4. And these were seen as similar viruses, similar pro-inflammatory toxins such as cytokines and prostaglandins, which are produced by the mast cells in the brain. And these were stimulated and overstimulated, and we saw high levels of cytokines in the brain, and this was causing the problem. In November 2020, finally, they showed in SARS-2 in COVID-19, they showed that the brain, the main entry is via olfactory nerve pathway, just as Maldovsky discovered in 2003. They also said there was a problem in the blood-brain barrier, and that was all based on their work, but it was the same I was saying. So I have developed a theory about the stages leading to long COVID, and it's never just the COVID. There's physical damage or abnormality affecting the drainage in the perivascular spaces of the cribriform plate, the olfactory pathway, but also what's of note is the optic pathway, the trigeminal pathway, and the auditory, the vestibular cochlear, that's the auditory and balance nerves effect of the ear, and all nerves coming, the cranial nerves, all of them have a perivascular space around the blood vessels supplying it. So they all have some drainage. And there's drainage down the spine. And if they get problematic because of trauma from the head, trauma at birth, it might be congenital, it might be inherent. And the spine as well it might just not happen because of an injury. Often there's an injury that triggers it, but it doesn't have to be. It could be build up for many, many years. Emotional trauma, physical trauma, immunological trauma, infection sensitivity, allergies, all those and environmental trauma. We know about epigenetics. We know genes can be switched on by environmental toxins. And environmental toxins are really, pollution can cause major problems to the nervous system, especially heavy metals, because metals are attracted to fat and they're lipophilic. And the brain is very fatty, the nervous system is very fatty, so they're drawn to the fat. So you have good stress and bad stress. I always say to people, joke, good stress is being married, bad stress is being married to the wrong person. Life is stressful. Kids can be stressful. I always say, joke as well. I say stress is inherited. You get it from your kids. And it's so true that there's lots of kids who through no fault of their own, cause a lot of grief and stress to the parents. And this is what we're seeing. Sympathetic overload, the sympathetic nervous system is one final trauma, and it's usually, and in long COVID, it's the COVID virus. That's the final trauma. And even though COVID virus is to do with to do with the lungs, it's much more affecting the brain than anywhere else. The sympathetic dysfunction that occurs causes a backflow of lymph, which causes toxins to come into the body and into the brain and into the spinal cord and cause major problems, which causes worsening increase in toxicity in the brain, which eventually the body says, enough. I've had enough. The hypothalamus can't balance everything anymore. It's like the hypothalamus is like a big pole on a tightrope walk, trying to keep it balanced. And ME patients and non-COVID patients have very, very small balance mechanisms, so they're falling off all the time. And this retrograde lymph flow is a result of all these things happening. Eventually, it says enough's enough. And osteopathy was founded by Andrew Taylor Still, and he said years ago, over 100 years ago, Lymphatics are closely and universally connected with the spinal cord and all the other nerves, and all drink from the waters of the brain. And Sutherland talked about this when you tap the waters of the brain by compressing the fourth ventricle, just what Laura Lewis and her team in MIT have done. Visualize that lymph node has holding some poison that's gathered there, changing the constituency before the lymph is moved along into the venous system. So the physical signs, I've talked to a couple of them, the spine and the breast tissue, and also the cranial flow is never moving well. But there's also a couple of other signs that I've discovered, that most patients with ME have major, what we call varicose megalymphatics. And these varicose megalymphatics are huge vessels like varicose veins, but they're not veins because they haven't got blood in them. And this is what I discovered when I examined the breast tissue. I first looked at the spine. You can see the spine in a very classic case. And then the varicose lymph is because of a backflow. It pushes backwards and forwards and backwards, and you create a varicose lymphatics. And this is taken, these were the first photos ever taken of varicose lymphatics. And you could see quite clearly on the diagram the valves between the lymphangions. So the lymphangions are like tubes, it's almost like sausage, very small sausage-shaped tubes, and they're attached to each other. So you can see the valves there quite clearly there, and there's a valve. And we need to drain the toxins out. So the treatment is based on that. But the thing is, we don't often see this with patients, but we can always feel it under the surface. We can, with patients with ME, we'll all have these physical signs. And here's a collapsed valve, and that's the other side. These are both ME patients, and that's the other side. And then we had one of the first ME, long COVID patients coming to us. She was an elderly woman, and she had the most incredible varicose lymph on her breast tissue. Just look at those. And we know they're varicose megalymphatics, not varicose blood, because they're colorless. They're the same color as the skin tone. They're not got any blood in. And in radiologically terms for long COVID, we've found spaces in the perivascular space on the left. These ones here, there is a sign of those are quite enhanced, enlarged spaces, perivascular spaces, that have been reported on by the scientists looking at it and saying, we found this, we don't know what it means. Well, we do. There's a backflow of fluid into the vein. There's also the brain stem has a problem, and there's certain areas of the brain stem that they have discovered. Vuatal in looking at COVID-19 found there was definitely problems affecting the autonomics, motor sensories, behavioral, cognitive, and mood-related functions, all stemming from the brain stem as well. Susan Vernon is one of the lead doctors and scientists involved in Idaho, in the center in Salt Lake City, and this is the Bateman Horn Center run by Dr. Bateman and Dr. Horn, and this center I was there I met some of the center. I was teaching in Utah last year, end of last year, and they were really interested. Oh, actually, no, it wasn't last year. It was this year. I forget. It was in January. So yeah, I forget. So many things happen. So this January in 2025, just when their paper came out, and basically they looked looking at long COVID, what's the incidence of long COVID and ME, and they looking at the determination of the incidence and prevalence of them both, and they found that ME CFS is 15 more likely to develop in COVID-19 survivors. 15 times more likely, because most of the long COVID we're seeing morphs into ME. So ME CFS is 15 times more likely to develop in COVID-19 survivors. And post-COVID-19 or long COVID overlaps with most of the symptoms of long COVID, the ME/CFS overlaps with most of the symptoms of long COVID. And early diagnosis can profoundly improve disease and manageability and patient outcomes. And that was in January. So it's really exciting. And then just last month, a paper came out from Australia looking at the glymphatic dysfunction, the glymphatic system dysfunction, and the blood-brain barrier, correlating with the blood-brain barrier dysfunction. And this used certain scanning techniques, and it was really, really good neuroscience, this. And they have actually shown, the study suggests that long COVID cognitive impairment is at least part related to a compromised blood-brain barrier, allowing influx of potential toxins and disturbed lymphatic system. So when there's more toxins coming in, it's going to shift the balance to almost certainly getting the illness. And as I said, and a disturbed glymphatic system, reducing appropriate drainage of such toxins could serve as an important non-invasive biomarker to identify these paravascular drainage abnormalities. But then not talking about the treatment, we've got the treatment for it. So what toxins are we talking about? We're talking about viruses. We said that. We're talking about yeasts and bacteria. Lyme disease is related to neuro-lymphatic problems as well. Parasites, pesticides, all these things, and heavy metals. And in my book, I talk about heavy metals. And it's something we can help with chelation. But there's a patient said to me that she feels that she's got that magnet's attracted to her. She's got lots of metals in the body. So I tried it with some neodymium magnets. And the theory would be, if there are toxins, heavy metals spiraling round in the blood vessels and the lymph, if there's a backflow of lymph, it's going to build up with heavy metals around the lymph capillaries, and this is spiraling around blood, and blood contains hemoglobin. And ME patients notoriously have sticky blood, have lots of clumps of red blood cells together, and this increased this increase in hemoglobin will be similar to the experiment of Faraday with spiraling coils of copper, which are non-magnetic. Once you have an electric charge, you create an electromagnetic field. And that's what we're doing, because in our bodies, we have the sympathetic nerves that are attached to sympathetic nerves. So the nervous system attaches to these nerves and fires off to cause an electromagnetic stimulus, which then leads to a much build-up of toxins and heavy metals. And then we saw the results of it. Magnets sticking to the spine where there's spinal problems, or magnets sticking to the forehead when there's head problems. And we saw it sticking in areas which are related to the symptoms, related to the condition. And healthy people just dropped off. So there is an argument to say that the reason why these metals stick is because it's non-magnet. It's not really magnets. It are magnets, but the reason why they stick is just stickiness, and the skin is very sticky. But we're going to do a research where we look at discs on both sides, and the University of Manchester plan to do this. We look at discs which are magnetic and discs that aren't, and we see which ones are attracted to the patients with these conditions. But it's very interesting. But the Perrin technique is basically a way of draining out these toxins, lymph drainage technique specifically to push against this backflow, because that's what's happening. And this involves cranial treatment, involves manual therapy, involves effleurage techniques, getting everything moving properly. And it's the concertina effect I always talk about, pushing down and pushing up, creating this pressure that pushes out all the rough stuff out of your body. And it also includes the siphon effect. The siphon effect is basically like these pictures show. I always joke, no offense to any Liverpudlian, because I used to follow Liverpool as a youngster, but I always joke that's how the Liverpudlians get their petrol. That's a Manchester joke. I'm sorry. For all you Liverpool fans, you can make it about Manchester people as well. But the siphon is a very known physical phenomenon. When you change the pressure, there's a pressure differential provided in the siphon by gravity. It will continue sucking up fluid from the fish tank and from the petrol can, and it will just tank, and it will just drain all the fluids away. If it drains the fluids with toxins, we're in business, and that's what the whole of the Perrin technique is to do with drainage of the brain, drainage of the spine, getting everything moving better, taking the toxins away. And we have self-massage routines and self-exercise routines and respiratory exercise routine to help the ribs move better and help the spine move better, helping drainage. And that's all freely available online. We have done some studies looking at the pilot studies showing that there was actually an improvement in the patients who we treated in the early stages. And we have new research going ahead looking at other areas. But one of the other things we've done is looking at deep sleep. And we did a single case study in a long COVID patient, and it showed her heart rate variability during which is the measurement of autonomic controls in your brain, that the heart rate variability was improved just with the Perrin technique. This patient measured her heart rate variability with an electric device that was attached to a monitor, and she used this technique to measure her heart rate variability and also measure the deep sleep. And it showed that the deep sleep had improved with the treatment, but also her heart rate variability went right up to normal value. And I apologize. I'm sorry. It wasn't the heart rate variability. We did deal with the heart rate variability as well, but the study was done. Sorry, you can see I've just come back from Toronto. The study was looking at REM at non-REM sleep at the delta wave. Delta wave, as I said, the glymphatic system, the delta wave was where that Macon Nedergaard found that people's drainage occurred. So the glymphatic system mostly occurs during delta wave sleep, and it's deep respiratory, deep sleep. And this has been shown that during that deep sleep, there's a pumping mechanism. This is again new research coming out from Denmark, showing that during the delta wave sleep, there's a pumping mechanism that pumps that closes the blood vessels and opens the perivascular space. So we do see a change in heart rate variability with patients. But this study we did, the single case study, was on the deep sleep. So was deep sleep improved with the Perrin technique? And we saw that her system was better, her autonomic nervous system was definitely getting better, her symptoms improved. And as her symptoms improved with this patient who had long COVID, so did her delta wave sleep. And you can see at the beginning of the study that she only had in the first part only had 11%. No, wait a second. This is not. That was in a different study, different part. But at the beginning of her deep sleep, sorry, that's right, the deep sleep there. So the deep sleep is 6 minutes. That's a deep sleep. 6 minutes at the beginning of before she started treatment, and then further on, after the few months of treatment, she showed a 1 hour and 6 minutes of deep delta wave sleep. So this deep sleep was an important part of her glymphatic system. So the treatment does help the autonomic nervous system. We've got studies to show that, but we've got studies to show that it helps the drainage system as well. But the main thing is proof of the pudding is in eating is do the patients feel better? Very good that their deep sleep is improving and heart rate variability is improving, but does it actually mean that they're actually feeling better? And it was shown in previous studies that yes, patients do improve with long COVID and ME CFS. And I use the jigsaw puzzle analogy with ME, and I use it together with long COVID. And what I say to patients always is look at the corners and then the edge pieces. In a jigsaw puzzle, you need to go to the corners. So what are the corners? The corners are rest, relaxation, meditation, and pacing. You can rest, but you need to proper rest. Lie down in a darkened room during the day at one period, or sometimes few periods if you need it. Let your body recover and relax. Relaxation is so important, but some people can't relax, so therefore they have to learn how to meditate, use mindfulness, very important. But the most important thing I've been telling people for years with ME and now with long COVID is pacing. Half of what you feel capable of doing. So important, half of what you feel capable of doing. And sometimes it's too, there's so many other things. So what's the Perrin technique is the edge pieces of the jigsaw puzzle, and all the different diets and talking therapies and chelation and supplements and adaptogens are all part of the middle part of the jigsaw puzzle, of the center, the sea and the sky. And sometimes it looks too difficult. But if you do start with the corners and then the edge pieces, then and add things to it, it's much, much better, and you will get a recovery. And eventually you'll get the picture, a perfect jigsaw puzzle picture of health. But what talk therapy helps? What does psychologists, does that help these patients with long COVID? Some long COVID patients have major psychological problems and major affected disorders like bipolar, depression, anxiety starts after having the COVID. So what's happening there? It's the limbic system, the emotional side of the brain. So we know that is there. And also patients get fed up being sent from pillar to post. So there are NLP techniques that do help reduce stresses and the best one I recommend is ACT, Stephen Hayes's acceptance and commitment therapy, where you accept that life is not the most pleasant thing. I've got words for it, but we're online, and I don't want to offend anybody. But life is not that good sometimes, and most times, and therefore you just have to accept it, and then concentrate using mindfulness on all the good things. ACT helps the person accept to be the present moment and learn to accept painful, stressful thoughts, and then is useful to help in not just in personality disorders, but also in chronic pain. Counseling, talk to the patients. If you're a practitioner and if you're a patient, always good to talk, to share a problem, shared is a problem halved. We often recommend other things like EMDR, which is also known as eye movement technique. But the mind is one part of it. The body is another part. And the body's immune system and gut are all part of this triangle. And we need to eat healthy foods. And I always say eating healthy foods, organic food, is healthier. No food we put into our bodies now is really healthy. Because there's so much toxins in the environment, as you know, as the Academy of Nutritional Medicine and Gillian and everybody else, we know there's massive amount of toxicity in the foods and the water and everything. So we can help the brain work better by having long-chain polyunsaturated fatty acids, which help heal the brain. My very good friend, Professor Basant Puri, did a lot of work on long-chain polyunsaturated fatty acids for ME, CFS, and the Academy of Nutritional Medicine have recommended for years using omega-3, omega-6 fatty acids, especially the EPAs and then eventually DHAs. And that's all important to help the brain, which is very essentially fatty tissue, work better and help the nervous system work better. Variety is the very spice of life that gives us all its flavor. William Cowper couldn't have said a better thing. And people ask me, what diet do you recommend? When I say the diet that works for you, there's the keto paleo diet, there's the raw diet, raw vegetable diet, there's the you can just go down having vegan food and or vegetarian. Some people eat no meat at all, and some people lots, and it helps them. So what's going on? You have to, every person is individual, and you have to make the diet that's right for them. And one of the best advice is we've heard this again and again from different nutritionists that I've spoken to and worked with. They all say the same thing, that we need lots of different colors. So the rainbow diet, as long as you can manage and tolerate, you can have lots of different vegetables and fruit. But as long as the different colors, you're getting lots of different nutrients and minerals. For the advice on exercise, we don't advise exercise to get out of this illness. The more you push yourself, the usually worse you are. But there are gentle exercises to keep the spine moving, and they're all online. My book was out in November last year and is doing well and is available throughout the networks. And you can get it, you'll be able to get a Kindle version as well. And it's a must for any practitioner wanting to do my work. The future, we have research, as I said, we are going ahead. We hopefully have new research facilities in the future to be able to look at scanning and everything. This is hopefully what we're working for at the moment. So just remember that COVID is a condition that has led to this long COVID, this post-COVID infection, and this long-term results of high levels of inflammation in the brain can be drained away by the techniques we do and I teach all around the world. And just remember, after the plague came the Renaissance. So thank you very much.
Thank you so much, Dr. Perrin. Absolutely tremendous, fascinating information.
I'm sorry, I lost the plot a slight bit in the middle, which is
it's a little bit longer than our normal webinars, and so we may need to book you in again to answer questions, because we've had so many. Do you have time for us just to ask a few?
Yeah, I do. Yeah,
I know you're tired as well, poor soul.
No, it's okay. I especially didn't eat any dinner yet. I just sipped on. No, caffeine's not that good for you, but for doing seminars, it's definitely recommended.
Well,
Bit of caffeine boost. Yeah.
I'll start at the beginning of the chat and then go to the Q&A, and
Okay,
we'll
yeah.
manage to do a few of them. Suzanne asks, how far have you seen dental issues affect your approach? And by that, she means structural, toxic, and infectious.
Well, I mean, most of your people know Klinkhart's work, and when I first met Dietrich, was oh God, I don't know how many years ago. It was with Andy Wright, who many of you remember, who sadly died a couple of years ago now.
Mm-hmm.
Very, very great. Also, no, it's last year he died. And Andy and I went together with John Roberts, who's a well-known mercury-free dentist, together in, I think it was Leeds, to listen to Dietrich talk all about the evils of mercury. In those days, that was it. Everything was due to mercury poisoning, according to Dietrich. It's changed over the years. But for years I've sent patients to mercury-free dentists like John, and John Roberts was one of the, and he learnt integrative medicine in America, John, and learnt all about cranial osteopathy as well. And he worked alongside a lot of the things I did. So dentistry is very important. Now, the thing is, do you always take out all the metals from the teeth? If you have amalgam fillings, should one do that? I would say wait till you've got if you're in a very bad state. The removal, even by the best mercury-free dentist, is still a risk of it. So I'd say wait to get yourself a bit stronger if you're very weak. But but people with lots of amalgam fillings and they've got ME or long COVID, they're definitely going to be affected by it. Yeah.
Mm. And then linked to that is the extent to which chronically infected tonsils affect your approach.
Exactly. So chronic, I mean, a lot nowadays they don't take the tonsils out until you've had it 7 times in the year. It's
Yeah.
it's been the new rule for the last 10 years, I think, or maybe even longer. But years ago, everybody, it got a bit of infection, you had a few antibiotics, then you had your tonsils whipped out at 5 or 7, usually around 7. Tonsils are very important, a very important part of your lymphatic system. The appendix is a very important part of your lymphatic system in the gut as well, but it gets removed. Tonsils, if they're not removed and they get very, very inflamed all the time, can also cause a problem. So you've got to weigh up. And if the person gets many, many infections and tonsillitis and quinces when they get ulceration in the tonsils, then maybe it's time to remove the tonsils. Yeah. So it can, if it chronically infected, will affect the ability of your body's immune system to work, and it will affect
and contribute to PANDAS,
absolutely. Yeah.
The autoimmune neuropsychiatric syndrome. In what way might Lyme disease affect the glymphatic
Right. Well,
system?
Lyme disease, Andy Wright, who I mentioned, the doctor in Bolton, was a very close friend of mine, and we worked together for many years until, sadly, he wasn't allowed to treat Lyme's anymore by the General Medical Council. He introduced me to Lyme disease as early as I was doing my work with ME, and he had live blood analysis to monitor it. And I've dedicated through Looking Glass to one of the people I've dedicated the book to is Andy Wright. But my term for Lyme disease is neuroborreliosis. It's when the bacteria go and the cytokines created and all the inflammatory toxins created from the virus, that the body, then the mast cells fire off, and you get prostaglandins, you get interleukins, interferons, cytokines, which are there for the immune system. But if the drainage isn't working properly, or drainage is working the wrong way, as we see with ME and long COVID, it pushes the toxins back into the brain, including the spirochetal toxins that cause Lyme disease, the Borrelia. So the Borrelia goes into the brain and stays in the brain, and you get this neuroborreliosis, not draining away. The toxins that are produced because of the infection don't drain away, and your body and your brain becomes more and more inflamed. And that's what causes Lyme disease. So a lot of people get bitten by a tick, or they don't have to be bitten by a tick. We now know it can even pass through placenta, Lyme. But the Borrelia will hit the person, and the reaction to the Borrelia and the Borrelia itself will not be drained away, will be drained the wrong way and go into the brain, causing this neuroborreliosis. And that is what we call chronic Lyme disease. And therefore, the treatment can help. And I've helped quite a few patients over the years with Lyme disease with my techniques, on top of other nutritional support and
other infections
supplement
as well.
Pardon?
That link other infections too, of course.
And other infections as well. It's not just Borrelia. There's Rickettsia, Ehrlichia, Babesia, Bartonella. There's a whole group of them. There's chlamydia pneumonia, and there's a whole and these tests are done by very, very. I mean, my connection with AONM has been for years. We've used the AONM links to Armin Schwarzbach and the Armin labs. So all my patients go through the AONM if they need to have the Ellis spot test for Lyme. Remember, notoriously. Sorry, I should stop sharing the.
Sorry, I forgot to ask you.
I forgot to stop sharing. I don't know. Share. How do you stop share? Stop sharing. Press stop sharing. Sorry, I've stopped sharing now. Sorry, you can see it much more now. Sorry about that. Yeah. So basically, Armin Schwarzbach developed the ELISpot test. As said, Andy Wright, Dr. Andy Wright used live blood analysis, but the notorious ELISA test and the Western blot are so bad at positively diagnosing Lyme, 60 to 70% false negatives. So that when the person comes back from their test and saying, "Oh, I've had a blood test and it showed I haven't got Lyme," well, 60 to 70% of those have been shown to be wrong.
You know exactly what's going on. Yes.
So we use always the ELISpot test now. And we always go to Armin. And they do lots of other tests for other infectious diseases, which can linger on and lead to ME and now long COVID. So the COVID might be the trigger, but there was the problems before of neuro-lymphatic problems. So somebody will get the idea with COVID, going back to COVID, is that you have COVID-19, you might have it really, really severely, but don't get long COVID because you've not got a neuro-lymphatic problem. If you have a neuro-lymphatic problem, and it's usually in women, and we see this again and again, and there's a reason for that, because women...
Yeah, that's one of the questions, actually, what the reason for that does seem
right,
to be.
So there's reasons for it. It's in my book, and it's in all my books on ME as well. One is hormones. The hypothalamus is always stressed by extra changes in hormones, and who has more hormonal changes, more hormonal flux, male or female? It's definitely female. And then you've also got leptin, and this was discovered by Jared Younger in leptin is much more female hormone than male hormone. It's an adipokine, it's a cytokine, the leptin that actually it attaches to the glial cells, to the fat of the glial cells, and it controls satiety and hunger. And we see this is a major, as the leptin levels goes up and down, so do the symptoms of ME. And we're seeing this with long COVID as well. And this is a much more female hormone. So that's the two reasons from the hormonal point of view. But then there's a structural point of view. If there's a backflow of lymph going up and up the head into the brain and down into the spinal cord and into the rest of the body, the first port of call is going to be breast tissue. And women have much more breast tissue than men on average. So there's much more congestion of the lymph and much more irritation of the nervous system around there than in women than men. So those are the three reasons why you get ME in much more in women. You get fibromyalgia, much more in women. You get long COVID. Even if the COVID has been affecting men more men died of COVID. It's the long COVID patients that is mostly women. And you get other things like lymphedema and lipedema affecting mostly women. We can go on and on and on. And that's what we see with this condition.
So much. I'll just ask a couple more questions related to infections because you've given us such fascinating answers just now. Sheila asks, is ME and CF, or are ME and CFS always related to having had a virus? And Tara asks, could EBV be one of the preceding triggers?
Right, well, Epstein-Barr virus, one of the names, and there's a very famous book called The Disease of a Thousand Names by Dr. David Bell. And one of the names for ME years ago was chronic Epstein-Barr syndrome. That's one of the names.
I didn't know that.
So they used to think it was always Epstein-Barr virus. This goes back to the 1960s. It was always Epstein-Barr virus that triggered ME. It's not. And Bruce Carruthers, who was wrote the main author of the Canadian criteria for ME, and also the major author for the international consensus criteria. I got to know Bruce very well before he died in quite a few conferences. And he said, it's not one virus. He told me, he said, it's not a disease as we know it. And he was a physician. He said, it's a dis-ease, not a disease.
But it can be triggered by it.
It can be triggered by, it's more commonly triggered by a virus, but triggered, not caused. That's the key. If you go back, they find lots of different environmental, physical, emotional stress factors building up. And then one final trigger, usually a virus. And years ago, it was always believed to be Epstein-Barr, and now there's lots of other things. With long COVID, the trigger is always the COVID virus.
Yeah.
However, the causes of it are lots of different multifactors, but the trigger can be an emotional strain, can be a trauma. I saw a patient just this last week who was a doctor, a physician, a cardiologist who had his trigger to his illness was a major trauma, major injury in his body, and we see this as a trauma. It could be emotional trauma can trigger it. So it doesn't have to be a virus, no. And often, as Borrelia is not a virus, it's a bacterial infection. So it doesn't have, and it can be fungal infections as well. This is big. Fungal infections. You have people with sick building syndrome, and lots of mycotoxins. So mycotoxicity from you have mold being a major trigger for lots of people. If they live in buildings that are very old, that could be the final trigger.
Yeah,
So it's a build up and it's a final trigger. Yeah.
So many fascinating questions. We will definitely need to book you in, please, for a repeat session. One or two more, perhaps. Do you have any thoughts on how melatonin fits into this puzzle?
Melatonin, well, it's one of the sleep go-tos for people that can't sleep. Andy Wright used to always running the complete hormone clinic as he did. He used to recommend melatonin for most of his patients. It doesn't always work. Melatonin helps you get to sleep. It doesn't keep you to sleep. If melatonin does help patients, because it's the pineal gland is one of the circumventricular areas where there's toxins going backwards and forwards. So the pineal gland can definitely be affected by the toxins as well as the hypothalamus. So if you have the hypothalamus pineal gland axis affected, it can affect the melatonin levels. And we see and the whole diurnal shift and everything, when you have melatonin serotonin levels, you need them balanced. Otherwise, you don't sleep, you're wide awake. And it's not just it's the locus coeruleus and norepinephrine as a main part to help the delta wave, but you need melatonin to help you switch off to sleep. And I recommend, if you're going to take melatonin, get the slow release melatonin that releases during the night, and that works better for some ME patients than just standard melatonin.
Fascinating. Thank you. Perhaps just.
But you can stimulate. I mean, at night time, I remember in places where I've been all over the world, and when you go to climates where you go to up north into the Arctic Circle, where they don't have dark all the time, they have too much melatonin and not enough serotonin, and that's why people sometimes get SAD, seasonal affective disorder, in the winter, and that can affect ME patients quite a lot. So when they have too much melatonin, it's no good. It can make them too dry. They don't have enough serotonin. So that's very important. Yeah.
One interesting question here that's a bit counterintuitive. Why were so many physically fit and active people hit with long COVID, assuming their activity levels would have been helping with lymphatic drainage? Do you have any ideas about that?
What they talk about doing things more, they'll feel better. Is that the question?
Well, the question is that Vicky picked up on the fact that many physically fit and active people were hit with long COVID.
Yeah. Oh, yeah.
And she wonders why, considering their activity levels would have been helping lymphatic drainage.
Yeah, well, a lot of very fit and before they were ill, a lot of fit and active people, like athletes, and I did a whole seminar on a sports medical seminar on sports in long COVID, and we have the same in sports in ME. A lot of sportsmen, like years ago, there was lots of sportsmen developed ME, and we see the same with long COVID. And I was involved in sports medicine, so my first patient for ME was a cyclist. And the thing is that they're very super fit, and then they're pushing us with their bodies to the very limits. And then so that even though it's helping their cardiovascular system and everything, but the fact that they've pushed themselves and pushed themselves and pushed themselves makes them more vulnerable, and they often affect the spine when they're doing lots of activity. So exercise is good, over exercise is bad, and it's been shown that if people over push themselves, they increase the levels of cytokines in the body, they increase the levels of prostaglandins. So I say exercise is good, over exercise can really be bad. And so we see a lot of sports people, a lot of very super fit people developing ME, and this is and long COVID. And this is why I say it's not the worst illness in the world, but it's the cruelest. It hits people who are pushers, who are doers. They're pushing themselves to the very limits, in physically and mentally, in their jobs. I mean, I'm lucky because I do all that. And God forbid if I was my patient, I'd be my worst. I'd be my absolute nightmare as a patient. Because I push myself. I mean, I always tell my patients, pace, do half of what you feel capable of doing. And I do way over double that all the time. So why don't I have ME? I had Epstein-Barr virus. I had glandular fever. The reason why I didn't get ME and why I haven't got ME or long COVID, and I've had COVID and not got long COVID, because my neuro-lymphatic system, luckily, works and my drainage system works. If it didn't, I would have developed ME long ago. That's the key. And there's physical signs that we look for. There's 5 physical signs we can use, and it's in my books, and it's in my work, it's in my paper. We published the British Medical Journal in 2017. It was published there. The physical signs are very real.
Maybe we can finish with one more sort of Google question,
which
Jane asked right at the beginning, which was, I wonder what your view is on medicine and medics being more accepting of your work and treatment. Are we likely to see Perrin technique treatment being recommended in the UK?
All right. Well, I'll just paraphrase, and bless his cotton socks, Charles Shepherd, everybody knows in the ME world. The ME Association, if you ask them about the Perrin technique, they say we don't recommend the Perrin technique. Charles for years has said it's not scientific, and I have my enemies out there. Why are they so against my techniques? Because I'm not a drug, and this is the thing. If I was a drug, if I was able to stimulate pharmaceutical funding, then people would be much more interested. Years ago, my theories were completely out there. The scientists looked at me and said, "This is rubbish." The doctors walked out of my lectures. Neurologists wanted to crucify me, and because I was saying there was a neuro-lymphatic system and it was going wrong. There was no such thing as a neuro-lymphatic system when I did my research. It hadn't been proven at all, and people said there isn't. And ME didn't exist in those days, in the 1980s and 90s. A lot of doctors didn't believe in it. So it takes a long time for science to take over. Science has now validated everything I've said for the last 36 years since I started my research in 1989. Science has backed up everything I've said. And the one thing I will just finish on the ME Association's survey, and it was highlighted in a recent article by the Daily Telegraph. In 2010, 15 years ago, the ME Association conducted the largest survey ever conducted on patients with ME in the UK. It was their own survey. And number one of the 25 listed treatments, graded exercise, as you can imagine, was right at the bottom. Number one was pacing. What I advocate for years, pacing. Not pushing, but half of what you feel capable of doing. 50% rule, I call it. And that, universally, most of the countries have accepted that. Except maybe this country, which says 70%. But it's 50% is a half rule. That's doing physically and emotionally. Second on the list was relaxation, meditation, and resting, relaxation, meditation. So it was number two. Again, part of the jigsaw puzzle analogy. And number three on that list was the Perrin technique.
Oh, wow. Hmm.
And they just shelved that. They didn't want anybody to really to know about it. And I've highlighted it, and the Daily Telegraph highlighted it. And they say in that article, to paraphrase it, despite their own patient survey, the ME Association still banned around. If you look on the ME Association, we do not recommend the Perrin technique. We do not recommend it. It's not scientifically proven.
But things are changing, and things will change.
But the patients themselves said that that was 15 years ago. Things are changing. I'm not trying to create enemies here. I want everybody to work. I'm not the cure-all. I've never ever said I'm the cure, but my treatment has helped people for 36 years and is still helping people. It's part of the jigsaw puzzle. We need other things as well, yes. And some patients need. We don't harm, the first law is do no harm. And my treatment helps most people. Some people, it hasn't helped. And I'm sorry about that. We can't be 100%. No technique will be 100%. And and any technique that says, oh, we do this treatment and you're going to be better within a few weeks, just leave it well alone. These are chronic illnesses. They take time. But my working on the neuro-lymphatic system is so important because I believe that that's the key common denominator on all these illnesses. And if we do, my technique's been used in the neuro-lymphatics. We're the only technique that's been developed for the neuro-lymphatic system. If it goes wrong, the glymphatics, and it helps. It definitely helps.
You're spreading it worldwide.
And so hopefully it will help your patients who have keyed in today, and it will help the practitioners if they learn the Perrin technique.
Absolutely. Thank you so much. Just let us know where people can go in order to find out more about you.
Well, you can, if they want to know about the through looking, the book's available, Hammersmith Press. It's available online, on the Kindle.
And your website is easy enough.
And my website is it's www.theperrintechnique.com. And the exercises we give to patients, and we've done we did an NHS sponsored trial that hasn't been published yet, but it was a feasibility study to just on the self-massage routine. We've just finished that last year. That is the exercises which we recommended for that are online in a film. We have a film on our website, and it's all freely available, no subscription, freely available for people that if they want to look at the advice we give. It's all out there.
Oh, that's amazing. Thank you. And Scott, thank you very much for putting into the chat the fact, Scott Forsgren, that he's done a lovely webinar with you as well. I know that. Thank you.
Yeah.
Well, we definitely will have you back, time permitting. From your end, we'll always have time. Martin, if we could please copy over all the questions from the Q&A and the chat, because there are so many we haven't managed to answer. But thank you so much.
Thank you again to you, Gillian, and Claire. It's not here, but thank her, and for all that the Academy of Nutritional Medicine for all the work you do. And
could we send you a few questions that are probably a bit more urgent, like asking where practitioners can be found in other parts of the world, and maybe
that's on the website. That's on the website as well. There's a map on the website which has the nearest practitioner to you. I am constantly going to train. I've just been in Toronto training up a whole group of new Canadian practitioners. They're all on the map. They get put on the map as soon as they're licensed, and that's trained by me. And we have it's a growing number in Australia. I'm going to be there in November, training up practitioners in Melbourne, Sydney, Brisbane, and Perth, and hopefully New Zealand as well. But I'm constantly doing workshops around the world, and eventually I've got advanced practitioners as well who will be doing the training. And I'm not here forever. I'm working on longevity. I'm working on immortality, but I don't think Perrin technique can do that, unfortunately.
Tremendous, thank you. And I know you have an in-person conference in London next year. So when you come
Yes.
back,
Oh, yes.
maybe you can
And
tell
we're
us
having
more
an
about that.
in-person conference, and one of our wonderful lecturers is going to be Gillian.
Oh,
And
thank you.
the theme of our conference next year, it's for practitioners only. Unfortunately, it's always been practitioner only. It's a parent technique conference for parent technique practitioners. So, we have. It's this next. It's going to be May in London, and it's for the theme is the functional approach with the parent technique. So it's all about functional medicine and the parent technique.
Oh,
So
tremendous. Thank
and
you.
that's where your expertise lies,
Oh,
Gillian.
thank you.
Okay,
Thank you. Well, just to mention that we had our upcoming webinar next week is on the 10th of April. That's next Thursday. That's to answer questions from our previous webinar with Dr. Lee Cowden, and that will be beginning at 7 o'clock. So very much looking forward to that as well. But thank you everybody for being there. And again, huge thanks from everyone to you, Ray.
thank you so much. God bless.
Bye-bye.
Take care.
Bye-bye.
Happy Easter and Passover.
Oh,
And
thank you.
outside
Thank
of it.
you. Yes.
All your members. Okay.
Bye-bye.
God bless. Bye.